All right, everyone. We'll go ahead and get started on the chapter six. It's over lifting and moving patients. And before we get started, you may be thinking, huh, that's odd that we have a chapter over simply lifting and moving patients. But the reality of EMS is that we do a lot of it. In fact, we do it on every single patient encounter. We have to load them in and out of the ambulance, and we have to put them on the stretcher and package them and position them. So we do a lot of it. One. Two, patient position is an intervention, so that means it's a treatment. Okay, so we have to document how we did it, and it affects billing sometimes. There's a big piece to that, the financial side of it, and the legal side of it, with like documentation and being thorough in that regards. And finally, the reason that we spend an entire chapter on this is a really likely way that you could get hurt, right? Moving a patient, dropping them. It's also a really good way to get sued. Dropping a patient, right? So there's good cause for this chapter, and because of that, it's tested. So you know, I'm all about them tests and getting us points on exams. So it's tested. So we got to know this material. So that's kind of why I cover it. So we'll go ahead and get started. Now, I just kind of talked about the introduction to this, but basically, you know, we need to know how many providers we are going to be coming to the call, and we're going to end up talking about all these, so I'm just going to skip that for now. But let's just talk about the anatomy review, okay? You don't know this, I mean, it's a skeleton, obviously. Um, but you might get a test question that would say, at what areas is the weight of picking something up transferred into? Like, and it may have multiple choices, or you have to, you know, match or whatever. And the answers are, well, it's kind of logical, okay? If we're picking something up from the ground, right? Let's just imagine we're picking up a patient on like a backboard. Um, it first will go into your shoulder girdle, okay? Some could argue your wrist and hands as well. Um, Oddly enough, your rib cage, right? Because your torso has to engage, especially your abdominals and your core. Certainly your spinal column, okay? Your pelvis and your legs, okay? So there's a lot of ways that you know, picking someone up, it could be transferred into your body, like the distribution of weight. So just keep that in mind. How I think this will be tested is they'll say, you know, lifting a patient will likely transfer weight into, is it your, you know, jaw, or is it your knee? You know, is it your knee? You know what I'm saying? So just keep that in mind. Um, so uh, when you're lifting a patient, you know, your shoulder girdle, so your shoulder girdle is this, right? Your shoulder girdle should be aligned over the pelvis. What you don't want is your back bent. I'm going to show you that. Your hands are close to the body, right? Because if they're outstretched, right, then you might tip over. So you want to keep it close to your core. It keeps you tighter on balance. And if force exerted against the spine occurs in the central straight line down the vertebrae. I'm going to show you what this looks like. So what's funny is the book shows this as a correct example, and I think it's rather wrong. Um, I will say that he is at least bending down and not just like straight up like bending over and like picking the patient up. Okay, we see that, but uh, I think his back should be a lot straighter. It's not. It's curved. Like that's not good. Okay, so in order to not curve his spine, he needs to drop his hips closer to the ground and have his back straight. Like when I'm talking straight back, I'm talking straight, like a line, like straight back. Curving your spine like that is not ideal when lifting. This is how you get herniated disc, okay? If you don't know, you know, your spine sits, you know, your vertebrae sit on top of each other one by one. But what happens is in between each spine is this disc that's kind of squishy. And what happens is when you start bending your back like that, that disc can protrude like this, and that's a herniated disc. And so you get that from bending when you're lifting. The number of EMS providers that have this, innumerable. A lot of people have herniated disc, but especially in EMS because we end up picking up heavy people. So yeah, I mean, again, they showed this as an example of what to do. In my opinion, it's a little wrong. I think his back's still pretty bent. When we lift patients, Laura and Jeff are going to go over this. I want your back straight. Okay, you're going to look like a goober, like you're doing something out of like a 1980s aerobic class. That's fine. Okay, save your back. God only gave you one. You have one back. Use it. Be nice to it. Okay. I know so many EMS providers that have had back and shoulder surgeries because of the job. And again, that's why we're dedicating a whole chapter to this, okay? So, um, yeah, you don't want to do that. Yeah, like I mean that looks like a terrible idea. That looks painful. But you don't want to do that. Bend your knees, lift with your legs, okay? Um, don't be lifting with your back. Okay, I mean, this is back injury 101. Like it's gonna happen if you lift like that. Now, if you can't make the lift successfully, don't. Okay, call for help. Have someone else do it. Okay. Um, Remember, our safety's first. I don't care what they tell you in the vignette. I don't care if they tell you patients not breathing and this and that, but they're 600 pounds and you're the only provider. You tried moving the patient and could not get them to budge. What do? You call for help. Okay? Your safety first. No one else matters but you. Your safety first is always the right answer on the test and in the real world. Our safety first. Okay? If you're hurt, you make the problem a lot worse. We need you. All right. So the legs should be spread about 15 inches apart. Bring a ruler if you'd like. With your back held upright, bring your upper body down by bending your legs, not your back, your legs. Properly grasp the patient or the stretcher and lift by straightening your legs. You lift with your legs, not your back, okay? Keep your back straight. Do not lift a patient or heavy object with your arms outstretched. What that looks like is this. If I were to put, a 50-pound sack of flour in your arms like this, it's going to tip you over, okay? But if it's close to your body, you're going to be able to hold it a lot longer, okay? So when you outstretch your arms, it causes you to lose balance because your core's not tight enough to hold you up. So keep it close to your body, okay? Use gravity. It's on your side, okay? Hold your arms with your elbows aligned with the sides of your body, like this. Again, Laura and Jeff are going to go over this, but I do have my camera on for this. And then keep the weight you are lifting as close to your body as possible. I've said that twice. And avoid bending at the waist. When we bend at our waist, we're bending at our back. Believe it or not, your spine runs all the way through your waist, okay, down to your tailbone. So you can cause a lot of strain on your sacral and lumbar spine that way. So you just don't want to do that. Just don't bend at your waist. Keep your back straight. Now, to perform what they call a power grip, you're going to face your palms up. And you're going to keep your hands at least 10 inches apart, and you're going to insert each hand under the handle of the palm by facing up. So like this, and then curl your fingers like it's like grabbing a bar, and then and pull. That's the proper hold. Okay, that should have said proper. Yeah, power grip. Yeah, that's the example of it. Okay, makes sense. That's intuitive. That's how you'd pick something heavy up. So you should never grab the stretcher like this. You know what I'm saying? Like the palm down. Like that doesn't make sense. You want to lift it supinated. Yeah, last lecture. Like this. Okay. So palm up to the sky. Now, the where people get injured, and I've seen this, I've done this. Where people get injured is by not coordinating the lift properly. So someone thinks we're lifting on 3, but we're really lifting on 3 lift. And I'll show you what that looks like. So teamwork and very clear communication, eye contact with all the providers. Everyone heard my command that we are lifting on 3. Very important. Okay. Team and quite frankly, disqualifying and not using the people who shouldn't lift. Okay. There's going to be people in your agency that are recovering from a shoulder injury, or they're obese, or they're short, or they're not strong. I don't know. And it's not that they're less of a human or less of a paramedic or EMT. It's the fact that we don't want them to get hurt. And if you have firefighters or police officers or someone standing around that can replace them, replace them. Okay. If someone goes down in a team lift, you're all going down. And the patient's going to get hurt. What's rule number 1 of medicine? Do no harm. Okay. If you botch a lift, you're going to cause harm to you and to your patient. So it's okay. Okay. It's okay. Know your limitations. So basically what happens is when we're going to initiate a lift, we'll give what's called a preparatory command. All right, guys, we're going to lift the patient up on 3, and we're just going to stand, and, Jeff's going to wheel the stretcher up underneath the patient. All right. Making eye contact. You good with that, Jeff? You good with that, Laura? You good with that, Hunter? You good with that, Blake? Right? Yep. All right. Everyone's on the same page. All right. We're going to go ahead and lift on 3. 1, 2, 3. And we're lifting. Okay. And we're kind of making eye contact, and we're looking at the patient. We have situational awareness. These are all things that you think I'm being dramatic. I'm not. These things have to happen. You will get hurt. More than likely, you're going to if you were to stay in this your entire career, you will get hurt at some point lifting a patient. Like it's a very, it's risky. That's why I'm telling you about this. So examples of the commands, all ready to stop. Okay, stop. Right? Very clear and loud. Not all ready to stop. Okay, stop. It's very loud, authoritative. What I like to call command presence. You're the commander. Be a commander. Be a leader. Okay? All right, we're going to lift on three. One, two, three. And you're lifting. You know, you could do it the other way. I don't like this other way. You could say, all right, we're going to count to three and then we're going to lift. One, two, three, lift. Right? And you're lifting. Okay? So these are very important commands. And really, I can't stress enough. Not just saying them. All right, we're going to lift on three. One, two, three. But all right, guys, we're going to lift on three. Everyone heard me. They're paying attention. They're nodding. Or, yeah, 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 we're good. And then you lift. I'm serious. That actually has to happen. Okay? Now, you're going to wonder to yourself, Hunter, how do they test this material? This seems weird. I agree. It is weird. How they test it is they like to ask, when is it appropriate to do the rapid extrication move? Okay, fair question. When should you have had, what spinal condition would cause you to add additional padding when using a long backboard? It's kyphosis, scoliosis, lordosis, stuff like that. So that's how it's tested, okay? And it is tested. So let me tell you how we do this, all right? So body drag, right? So you're going to use the same body mechanics as like I just described. Don't be lifting with your waist and, arching your back and all that stuff. Keep the back locked in upright position. Don't hyperextend your back, as in don't like bend over too far. Or hyperextension of a back. You see this a lot. People will lift someone up, and then instead of just going like straight, they hyperextend their back and lean back. It's dumb. Don't do that. You see people do that with like deadlifts and stuff. Really bad idea. Don't do that. Keep your back straight. That includes flexion and hyperextension, okay? You can hyperextend your back. And again, you can bulge your disc that way. You can hurt yourself. So don't do it. So yeah, that's kind of what we talked about. This is just showing how you could drag a patient on a sheet. We're going to go over this in class and give you some really good examples of how do you put a sheet up underneath a patient that's laying on their back. Oh, probably never thought of that. It's easy. You roll them to their side and you kind of stuff a sheet up underneath them. And you roll them to the other side and pull out the sheet. But again, it's probably something you haven't done before. So we'll go over these in class and show you some good examples. Now, I want to point out this one. He has his knees bent and it's good, right? Typically, when you're under load, you don't want your knees completely locked out. If you're like dragging in something like that, you can cause hyperextension of your knee to where your knee could go whoop this way too far. You don't want that. Now, avoid situations like doing a body drag that involves strenuous effort lasting more than a minute. Okay, because we have that option in EMS. But yeah, know your limitations. Again, your safety first. I will say that. I'm being sarcastic. I shouldn't be sarcastic with y'all. But know your limitations. Okay, if you get hurt, you go down. The whole call is going down. Okay, so now moving a patient across a bed. This becomes important for a lot of times for billing scenarios. If a patient's bedbound, a lot of places, not the hospital district, but a lot of places want you to document how you move the patient onto the stretcher, whether it's done by a sheet drag or something like that. So this does become important, and we use this a lot. I'm a big fan. If the patient's on like a hospital sheet or a nursing home bed, I just take all their sheets off the bed and use their sheets and just drag them over. It's like you just wrap them up in a little cocoon hammock and just drag them over. It works wonderfully. Never had it. Well, it's pretty rare for sheets to break. I've had it happen, but it's rare. So don't worry about that. The sheets are a lot more resilient than what you think. So this is how we transfer most patients over to the hospital bed. So we just take the sheet off the EMS stretcher and just slide them over. It's really well. Again, it's a coordinated movement. All right, we're going to move you over on three. 1, 2, 3. Whoosh, move them over. Okay. So the 2-person body drag, I should have put a picture in here. It's fine. There's pictures in your book. It's 2 people dragging a patient. Okay. Now, moving forward, log rolling a patient. We're going to talk about this when we talk about spinal immobilization quite a bit. But log rolling is when you take a patient on their back and you're rolling them. Okay. And what we do is when we roll them, we push this stretcher up underneath them. And then we roll them back onto their back. So now they're up on the stretcher. So that's how we do that. Okay. We do this a lot, but it's a little bit of a risky activity because it requires coordination amongst not only 1, 2, 3, 4, but 5, including the patient, people. So it takes coordination, takes teamwork, takes dialogue, command presence. Everybody's got to know what's going on, okay? So you're going to kneel as close as possible to the patient. We're going to say, all right, we're going to roll the patient towards me, or we're going to roll the patient through the patient's right side. That's going to be towards Jeff. You might use a command like that. All right, making eye contact. Everybody's good. And then you're going to, all right, we're going to roll on 3. 1, 2, 3, rolling. And then All right, we're going to roll the patient back onto their back on three. One, two, three, rolling back onto the backboard. Okay. So that's how we do that. It's coordinated. It's in, it'll make more sense in the lab when we talk about that. Okay. Now, rolling a wheeled ambulance stretcher, I can't, you'll get some experience with these in the lab, but uh, really, this is a two-person job, which is really weird that we haven't found a way to make this easier for one person to use, but this is a two-person job. Uh, One of my first calls, I grabbed the stretcher right here, and I was pulling it through these ladies. I remember this like yesterday. Really nice house, and the stretcher got like the back wheels are free, so it like slung out like a tube behind a boat, and it smacked right into this lady's wall with the oxygen tank. And I don't know how it didn't punch a hole through this lady's wall, but it was violent, and I was humiliated. And the patient's like, "Oh, it's okay." She was very nice. I still remember her. But anyways, long story short, it's a two-person job. Don't try doing this one person. It's not a good idea. Um, One person at the head, one person at the foot. And I'll go a step further. It's at least a two-person job. If you are on gravel or uneven terrain or rolling through grass, you want a provider here and you want a provider here on the other side. You want as many people as it takes to do the safety. Remember, safety first. So, um, like I said, sometimes you might need four people. That's the same thing. Now, weight and distribution. I want to talk about this. Okay, if we have a patient, okay, here's the patient. Okay, and you might ask yourself, where is the majority of their weight at? Okay, let's say we have a provider grabbing here, 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 and here. Who do you think's going to have to lift the most? I mean, really think about this. Who do you think's going to have to lift the most? This guy and this guy. Okay, people are distribution of weight is in the top half. Okay, by far. So the majority of your weight's in your gut, your head, your chest. Okay, not your legs. Legs are pretty light. Even fat people have light legs for the most part. Okay, so these guys, this guy are getting a lot of weight. So keep that in mind. Okay, you may not want to stick the 100-pound EMT up the head. Put them at the feet. Okay. Um, the other thing you have to consider is their height, like the EMT's height. So I'm 5'11". I'm 6 foot. If anyone asks, um, I have to keep that in mind when I'm lifting with my partner that's 4'8". You know what I'm saying? If they're lifting something to their waist level, that's not my waist level. So you have to keep that in mind with like, where do we put providers based on their lifting capabilities and their height and the distributions of weight and whether we're using stairs or not. There's a lot of considerations, okay? So just keep those in mind. You want to do what's safe, okay? And you'll see this in the lab, There's going to be someone in there that's 6 foot, and then there's going to be someone in there that's in the 4 feet, and it's hard to lift a patient that way. But you can work through it. It just takes teamwork and communication, okay? Um Going up and down stairs, very difficult. Okay, mobile homes, manufactured home like trailers, they're all on stairs, so we do this a lot. And thank God we don't have like high rises in like Parker County, but um, carrying downstairs is difficult and it's risky. Okay, use a lot of people to do this. It's okay to call a second engine to come get some help. Like it's risky and we don't want to cause harm, so you might have to call for help. It's okay. Um, uh, don't risk your safety or the patient's safety to make the lift. Okay. Again, if you got to call for additional resources or have the fire department extricate the patient from the house or whatever, that's what you do. We don't get hurt. We don't do risky stuff. Okay. Now, planning the move, again, I told y'all this should be in an orderly plan, directed one voice. The team leader should be directing this in an unhurried manner. You can allow feedback from the team, but one person's making the commands on this, okay? Usually the patient or the person at the head, because the person at the head is controlling the airway and the C-spine, the cervical spine. Excuse me. So plan ahead, okay? If you know the lady at 123 whatever lane is 800 pounds, send two engines. Send help, okay? Like if you know it's a fat patient, send help. It's okay. We used to do that at the hospital district. I won't say what part of the town she lived in, the county, but if we knew when that address came out, we were sending two ambulances and two engine companies at least because she was 800 pounds. Not kidding, 800 pounds. Um, and she couldn't walk, and we would have to take a stretcher out of the ambulance, and literally, this is like I shouldn't say this on YouTube. It's probably not proper. Lay her on the floor of the ambulance, and like she was so big. Her pillow was the mattress. I would take the mattress, fold it in half so she would kind of sit up. She would not fit on a stretcher. And she was, the two times I transported her, like deathly ill, like dying. So we had no option. We couldn't leave her there. Um, so, I'll leave you with this. When uh, you can't do better than your best, and we're problem solvers. Paramedics, EMTs, physicians, we're problem solvers. And we had to solve a problem. We had to get this patient to the hospital, so that's what we did. We took her to the hospital. So one thing I'll say too, and I want to be clear on this. Um, avoid hurtful, and I'm not soft, but avoid hurtful comments when lifting patients. I've heard paramedics say, "Oh, we gotta lift her up." Well, I don't know what you signed up for, but we're in the business of helping people. And the lady that fell and broke her hip in the shower covered in feces needs our help. And that's our mission, and we're mission oriented. So just be aware of like your loud, excessive grunts and groans and bitching and moaning and all that stuff. We don't do that. Okay? These are people, and these are people that need our help. And I've seen a lot of people intentionally or not intentionally make some really, really not cool comments to patients about being upset about the lifting scenario that they've encountered. Okay? They didn't ask to fall down and poop on themselves. Okay? But that's our job. Okay? If you're not ready for that, this may not be for you. Anyways, that's enough on that. But just be compassionate to patients. Okay? We're in the business of helping patients. Um, yeah, share any issues that result in injury to anyone involved in the move, okay? That may result in injury. So again, if you're thinking, ooh, we're not going to make that turn, or we might fall down, or I need someone to spot me, it's okay if you're not the team leader to say, hold up, got a question. Have we thought about this way? Have egos here? It's fine. Throw out your ideas. If you have a better idea, I'm sure people will embrace it. They don't want to lift heavy stuff either. So just keep that in mind. Now the diamond carry, I'm going to show you. It's easier for me to show you this to you. That's it. One at the head, one at the feet, two at the side. Kind of makes a diamond-ish. So that's kind of that. This is what they call the modified diamond. It's hard to get two providers through a door. They're not going to fit. So you kind of have to do this weird handoff, turning stuff to get through a door and angling to get a patient through the door. So it happens. It's doable. Again, communication, teamwork, safety. That's the thing. The one-handed carrying technique. So basically, this is where like you all stand out aside and carry with one hand. Okay, and this is really helpful with like a Stokes basket or a backboard. We use this a lot when there's a lot of help on scene, like a bunch of firefighters or police officers or whoever, a supervisor, someone like that can help carry. So I don't have a lot to add on some of these. Now, emergency moves. This is tested. This is like where I'm telling you, like they're going to ask you stuff on this. Um, so we use these when there's a potential for danger before the assessment and care are provided. Okay. So what's an emergency move, right? This is like the car's on fire. And you got to get the patient out. The I don't know the patient's I don't know. I mean, that's probably the best example. The car's on fire. The car's unstable, something like that. And you feel like you need to move the patient immediately. And that's before you even assess them. It's like, oh God, if I don't move them now, they're going to die or have serious bodily harm. That's an emergency move. Okay? We didn't even assess the patient. We walked up, determined that like they're not getting electrocuted, like the scene's relatively safe, but it's like if I don't move them right now, okay, a patient in water, for example, if they're face down in water, you don't have to do an assessment to realize if I do not get them out of the face down of street water, like a few inches of water, or face down in the bathtub, they're going to continue to die or die. So you got to pull them. That's an emergency move. So think emergency move. If I don't do this, they're going to die or have serious bodily injury. Like that's when we use emergency moves. Okay. And this is how it's tested. Your patient is found in a smoking vehicle and you immediately notice the vehicle smoking and appears like it may catch on fire. What should you do? You should rapidly extricate the patient, pulling the patient on the long axis of the body. What? Long axis of the body? It's not. The long axis is the spine. So you're literally just going to take the patient and just pull down their spine, like pull them on their long axis. That's how you move patients, okay? That's an emergency move. Like that. So you're pulling them like with their spine down their long axis. That's a long axis, so that's an emergency move. Again, we do this in emergencies. Not because we feel like it. Emergencies. If they want you to pick emergency move, they'll make it clear that it's an emergency. Now, pull the patient's clothing. You can pull them at the neck, or you can pull a sheet or something like that. Okay, pretty obvious. Now, these are more emergency moves. Sometimes you can just take their arms and just yank them and just start pulling them back. That's an option. I don't like doing that. I feel like I'm going to break their arms and stuff or pull the skin off their wrist when I do that. I've done it. I don't like doing that though. I have done this before. It works pretty well. You tell the patient, I want you to, make a fit, grab your wrist. Or I've even told the patient, grab my wrist to where they grab onto me and I'll get up underneath them and lift them up. I reserve this for extreme circumstances, but I've done it and it works well. Okay. Again, we'll show you how to do this in class. Um, Now, these are one person lifts. Again, you don't got to be a hero. This is catastrophic. Like, this is not, I've never done this. Okay. So 10 years, haven't done this. So it's not common that you do this, but you need to know it's called a fireman's carry. That's what they call, I have it here. No, that's called a front cradle. Yeah. That's called the firefighter drag. This is called the one person walking assist. That's the firefighter's carry. And that is the pack strap carry. I didn't know the names of these. I'm looking at the book. So the more you know. Now, urgent moves. So these are moves where like you've kind of done a little bit of an assessment and you're like, this patient's not good. We don't have time to be messing around here. So they could be in shock. Remember, shock is simply the lack of perfusion, right? So the cells are not getting enough oxygen or glucose. Um, Altered level of consciousness. Okay, so they're kind of going in and out of consciousness. They're unconsciousness. Poor ventilations, so they're not breathing very well. These are immediate life threats that we need to address. And if we need to address them by moving them to getting them to a better environment to do that, then we do that. That's an urgent move. So remember, there's a difference between an urgent care and an emergency room, right? One's a little more extreme. Emergency room's more extreme. So an urgent move is like, yeah, we got to do something, but it's not like, oh my God, we got to do it right now. So that's the difference between the two. You do need. I know those sound very synonymous. They're not. They're not the same. They are dichotomous. They are different. So do keep that in mind. Now they have this thing, and we'll show you this in class, called the rapid extrication technique. When a patient is sitting in a vehicle, right, and they need to be urgently moved. So like, we do this. I've had patients like vehicles are on fire, or like they're starting to catch fire, or they're not breathing well, or they're snoring respirations, and I'm like, oh God, we got to get them out right now. So when you do these types of moves, again, you have to reserve these for life-threatening conditions or urgent conditions, because there's a risk of spinal injury. Like if someone's in a car wreck and they're that sick, they probably have some type of they could have some type of spinal injury. So the reason that a rapid extrication technique is used is you got to get them out right then. And so you kind of, in medicine, we weigh the risk versus reward in everything we do, including moving patients. So we weigh the risk of, well, if I leave the patient in here with snoring respirations, they're going to die. Or if I pull them out right now and fix their airway, they're probably not going to continue to die from snoring respirations, and I can help them. So you have to weigh, you have to weigh the risk, and the risk might say move them or not. So that's medicine. Everything we do is risk versus reward. Okay. Non-urgent moves. These are our standard moves, right? So patient stable. We'll carefully plan on how we're going to move this patient, right? Yeah, we adapt this case by case. People don't fall in the middle of a classroom like what you're going to practice, right? People fall between their toilet and the wall, covered in poop. People fall in the shower, covered in soap. People fall on the roof, like people fall down the stairs. Like people fall in weird positions, and it doesn't really matter. So just keep that in mind. Like we don't get like what you're going to practice in class probably. Someone just falls in the middle of the classroom floor. Like that does happen, but it varies. So you just gotta. We're problem solvers. That's what we do in EMS. We solve problems. So we got to solve the problem. Now, a direct ground lift. This is used when the patient has no suspected spinal injury found lying on the ground. Supine. What position is supine? It's laying on their back. What position is prone? It's laying on their belly, face down. So use when the patient will need to be carried a distance to the stretcher. So that's just a direct ground lift. Your book shows you that. We'll again cover that in class. An extremity lift. This is used for patients with no suspected extremity or spinal injuries who are supine or a sitting position. I reserve these for extreme circumstances. I'd rather do the one where I showed you earlier like that, but I've done them. But I reserve the extremity. That's an extreme case. The problem is when you do an extremity lift, you got to grab something, one. So if they're like old, which the majority of people we run are old, surprise, you have to worry about ripping their skin off by grabbing it. Okay, remember their skin is like paper thin, like literally paper thin. So you can rip their skin, cause skin tears. One, two, you can break their bones or dislocate them or snap them or whatever. And three, um, imagine picking up someone that's like flaccid extremities. Like it's not easy, and you got to lift them really high to get them up underneath a stretcher and then drop them back down. So it's just really hard. It's just not my preference. There's a lot better lifts than that, safer. Um, so yeah, we're gonna talk about some devices, but before we do that, let's talk about geriatrics. So if you don't know, geriatrics literally means the study of old, like medicine, right? So geriatrics is typically patients over the age of 65. Just like a pediatrician sees children, a geriatrics, see old people. Okay, it's a specialty of medicine. Um, but they have skeletal changes and they have brittle bones like osteoporosis, so their bones can break really easily, especially females, older females. They can become rigid, so they could have contractures to where their muscles are locked and they don't really move. So their muscles are so locked that if you were to try to unlock their arm from like a curved position, their bones might snap before their muscles will relax. Like that's an example of a contracture. You can see it in the hands too and stuff. And spinal curvature. So there's these conditions called this is an example of kyphosis. It's spelled like this. Yeah, if you want to sound sophisticated, you diagnose someone with kyphosis. Kyphosis is curvature of the upper spine, kind of like a hunchback. You'll see this again with osteoporosis commonly. I've seen this in wheelchair people because they're always bending over for one reason, and then again, osteoporosis, which is brittle bone disease. And basically, you have to think to yourself, how do you lay someone with a curved spine like that on their back? It's really difficult. Like, ow, could you imagine laying that patient on a backboard, like this patient? That hurts. You're going to cause harm. We don't cause harm. We do no harm. Don't cause harm. Um, so the problem is, what you have to do is you have to like put padding or voiding. So if I'm going to draw this, like this is the patient's head, and they're looking this way, right? They're looking this way. Okay, if they're wearing a hat, it's going this way. Here's their eyes. So what happens in kyphosis? This is their neck. That's their thoracic spine, and then this is their lumbar spine. Well, you'll see that they have in like here is curvature inwards. So you have to pad that area and you have to pad behind the neck as well, and you have to provide padding for them. Okay, that's how we treat that. This is an example of scoliosis. See how the back makes a curve like that? This is severe. It doesn't really happen too much here in the modern world. We screen for it in children. But that's scoliosis. Tell you how to spell that. Scoliosis. Okay. Now, there's a last one called lordosis. So again, your patient's looking this way. They're wearing a hat. It's going this way. Okay. Now, cervical spine, lumbar or a thoracic spine's fine, and then this is their lumbar spine here. Okay, lumbar spine, their lower spine, and so I'm gonna get hate on this. I know I'm putting this on YouTube, but I think of this as like the girl that's trying to puff out her butt to make it look bigger than it is. You know how like they can like bend in their like lumbar spine, like self-induced lordosis. That's what that is. May help you. So you might think lordosis, big butt. I don't know, but that's an example of lordosis. How do you treat it? Pre-hospital, you put padding in the voids. So you'd put like a pillow here or something like that to pad that. Now again, this isn't just girls trying to puff up their butts. It happens as a pathology. Again, osteoporosis mainly. Okay. These are typically older person diseases, by the way. You don't again geriatric slide. You don't typically see that in young people. They can have skin changes. I talk about the skin tears. You got to be careful gripping old people's skins. You'll do it once in your career. You'll rip someone's skin off, and you'll realize it's nasty, and you'll realize, yikes, don't do that again. But it's okay. It's kind of almost like a cardinal moment. You'll make that mistake once. It's not okay. We don't cause harm, but I'm saying it's going to happen because even when you try your best, their skin is that thin. I can't stress how thin it is. It tears very easily. It's almost like taking like a paper towel or like a piece of paper that's like printer paper that's really wet. It just tears. It like folds up and tears. It's really gross. But it happens a lot. It's very common. So they're afraid. They could be hard of hearing. Just be sympathetic. Just like kind of with obese people, we got to be sympathetic and compassionate and give a good approach and slow down. Okay. No one died from spending an extra 20 seconds for doing a lift. But you know how patients do die? Lifting them in 2 seconds and dropping them on their face and giving them a brain bleed. So, again, do no harm. Don't lift the patient so fast where you drop them flat on their face and kill them instead of spending an extra 20 seconds to plan out the move and make sure you're safe and the patient's safe and everyone's safe. That's the best practice. I talked about bariatrics. Bariatrics means the study of overweight people, obese people, and the diseases associated with that. We live in Texas. Our portions are huge. The majority of patients are obese. Not my opinion. The majority. I'll say that again. The majority of patients we encounter will either be obese or geriatric or both. So just be prepared for that. I've said, and it's not jokingly. Young, attractive, healthy people don't call 911, right? It's people that need our help that are old and overweight and poor, that don't have a lot of money, that don't have access to a lot of resources, that can't afford to stay healthy. That's who calls us. So be prepared for that. That's what we do. That's who we serve, and we're glad to do it. So we have these things called bariatric stretchers. I'll show them to you. Now, the wheeled ambulance stretcher, I can tell you the one that we used to carry at Life Care, I think it was like 115 pounds, just the stretcher itself, empty weight. So they're pretty heavy. Um, they have a foot in and a head in, blah, blah, blah. They have guardrails. Make sure the patient wears the seatbelts. Now, this is what we carry at Life Care. That's a Stryker Pro. Love them. Big fan. Anything red on a Stryker stretcher makes it move. You'll go over this in class. You'll get very comfortable with these because a lot of what we do is moving patients. So that's a Stryker stretcher. There's a battery here, like a DeWalt battery. And so it uses hydraulics to lift the patient up and down. Big fan. Total back saver. Now, there is a bariatric stretcher at 750 Sanderson Street at the training center that we use a lot in training because it doesn't work on our ambulances with the new power load, so we use it for training. We bought this several years ago, the district did. We don't use it a lot, but it's available if we needed it in the streets. But the stretcher's wider, so it can carry a lot more weight. I don't know the weight limits on that. I'm going to be lying. I'm going to shoot out a number. I think this one's limit's like 650, if I remember right, pounds, 650 pounds. I want to say this one was like 800. Which really isn't, patients get that big, so just keep that in mind. They have a wider wheelbase. These handles are like a lot more taller up. And yeah, that's a Barry. Sometimes you'll hear the slang, oh, the Barry stretcher. That's what they mean. It's just a stretcher for clinically obese people, for bigger people, okay, wider people. So the pneumatic stretcher, this is, I just explained this, they're hydraulic, okay? They run off a battery. Big fan, they save your back. We'll show you a stretcher where you have to manually lift it up with your partner. It takes two people. And we'll show you a stretcher where you push a single button and it raises it up with pneumatics, hydraulics. So moving forward, some stretchers obviously have, an IE or an IV pole, right? Ours are right here. Typically, they fold down. Sometimes we used to have one that would carry our monitor, like our life cap monitor that does all the vital signs. I don't know if they still have that. They definitely all carry oxygen. I've never seen a stretcher that doesn't carry oxygen. And they have extra wheels below the head end. That's this right here. Like those are, I'll delete it, but those are wheels. So if the stretcher's flat, it has even more support. So it doesn't like teeter-totter. Okay? Portable folding stretchers, don't see a lot of these in modern day med and EMS, but they exist. Okay? Don't use a lot of that. Now, flexible stretchers, these we do use a lot. We call them mega movers. It's not my opinion. It's the name brand. It's called Mega Mover. And it's like a tarp with handles on it. And they can hold like probably 600, 700, 800 pounds. And so if a patient's on the floor, we'll roll the tarp underneath them and lift them up that way onto the stretcher. It's my preferred way of lifting a patient up off the floor that doesn't have like spinal injury. Big fan of the Mega Mover. But that's kind of what they're showing you here, okay? So flexible stretchers is kind of like a tarp with handles, basically. That's one way to remember that. Backboard, the other word for these is they'll call them long backboards, or they could call them a long spinal board. Okay, long discussion on these. It's a whole nother chapter. But we use these for patients that have suspected like back injury, spinal injuries, of course, extrication from a vehicle, we use these on patients that are found lying down on the floor or in a bed. We'll put them on the backboard and move them and either take them off the backboard or leave them off the backboard. Most are made from plastic. Back in the day, they used to be made from wood. Wood is a great way to carry pathogens around and antigens. So plastic's really easy to decontaminate. So most of them are plastic. And also plastic is radiolucent, so you can shoot an x-ray through that. So you can basically have a patient laying on the backboard and slide a film up underneath them and shoot the X-ray without taking them off the backboard. So that's kind of nice. So the radialism. This is called a Kendrick's extrication device. Again, you'll cover this in class, but called a KED for short. But a Kendrick's extrication device is called a short backboard or a short spinal board. And these are basically used to extricate patients from a vehicle in the sitting position that have neck or back pain. They have some other value too. I won't confuse you with those values. We'll go over those in class, but you could use these. I'm going to talk about it, but yeah, they have other value. But basically, I want you to know KED, Kendrick's extrication device. It's used for the seated patient that needs spinal immobilization. Vacuum mattress. I've never seen one of these, but they look cool. Basically, you put the patient in like on the mattress, okay, and the mattress has like these. Like when you sit on like a beanbag, it has those like pellets in it, those foam pellets. It has that in there. And so you basically end up conforming it to the patient and you suck with a vacuum the air out and all these little like beads kind of like get tight close to each other and it immobilizes the patient. I personally feel like I'd panic inside one of these, like claustrophobic, like I couldn't do that. But these are used like a lot, in like ski patrol, like extricating patient down a mountain. I know like Frisco Fire Department uses these a lot for like major accidents, like major multi-system trauma. They'll use these. So they have value, okay? And the way this could be tested is they do reduce the risk for hypothermia. What's hypothermia? Think about it, hypo below, thermia temperature. So it reduces the risk of low temperature, hypothermia. But of course there's a weight limit on these. You can't be like 3 foot wide and fit in that. So a basket stretcher, sometimes these are called, a Stokes basket. Whoops, sorry. A Stokes basket, that's the other name for it, just letting you know. They'll be called a Stokes basket, and that's a basket stretcher. So basically use these a lot in like with rough terrain and stuff. Like to extricate a patient from a roof, you're going to use a Stokes basket for sure because it has like handles and it kind of like, see how it kind of like cups the patient in there a lot better? It kind of cups them. It comes up like on the edge. Now, this is what I call the broken hip stretcher, also known as the scoop stretcher. Big fan of the scoop stretcher. It saved more lives than anything. Not really, but it's a great, great, great tool. So the scoop stretcher scoops patients. How it does it is it disconnects here and here, and it breaks into two pieces. So what you do is if the patient, typically you could log roll a patient onto a backboard. Well, if the patient has a broken hip or a broken pelvis, you can't log roll them. Could you imagine the pain of log rolling someone onto a broken hip or pelvis? It's going to be excruciating. So if the patient's laying on their back, what we do is we take the scoop stretcher apart and we scoop it back up underneath them and reconnect, click, click. And that now the patient that's up underneath them. And so you can lift the patient up. So that's why I jokingly call this the broken hip stretcher, because if a patient has a broken hip on the floor, which they typically are on the floor, I just say, hey, go get the scoop, because I'm going to scoop them up. And that's how we do that. So these do come in plastic. I think the plastic ones are a little bit better. I'm not paid by them. I wish I was. But I think the plastic one is a lot better than the metal ones. You have to be careful with these because these can pinch the patient. This is actually, it's not like you couldn't shave with it or cut vegetables with it, but a fairly sharp blade. So if you get someone's fat or like skin or hair caught up in that, it's very painful. So what I found I've had to do before, and we'll cover this in class, you have to kind of like rock the patient back and forth to get the scoop up underneath them. But big scoop fan, it works great, Stair chairs, I'm a stair chair guy too, okay? I would rather stair chair someone than carry them or have them fall downstairs and get us all in trouble. So a stair chair, as the name would imply, it's a chair that goes downstairs. So you basically have a provider holding it here, and you lean the patient back onto these tracks, and you slowly take the patient down or up the stairs on those tracks. Really, it's down. We usually take patients downstairs. That's how we use that. It's a really good device. Again, I'll show you this in class, but every ambulance has these. They're called stair chairs. Love a good stair chair. Make sure the patient's locked into them. You really shouldn't use this for an unconscious patient. I'll add that. It's a little value. Okay. What you don't want to do, but you get thrown into this sometimes, is again, you can't use the stair chair if the patient's unresponsive. I just said that. Um, so sometimes what you have to do is you have to take the patient down the stairs with on a backboard, and it's really difficult because think about this: the patient at the feet is like way up here, trying to keep the patient like from like sliding off the board, and the patient up top is like way down here, like hyper, like way flexed down or extended down to try to make up on that height difference. So it's very difficult to do this. It takes a lot of coordination, but sometimes you just gotta, like, it just happens. So again, coordination, calling for additional help, remaining safe, ensuring your safety, doing no harm, all those rules still apply. Okay, we're almost done. Hang with me. There's these things called neonatal isolates. Okay, neonate means like a baby that was just born, not an infant, but like just born. An isolate is to isolate them. And so basically, babies can't thermoregulate. They can't keep their temperature where it's supposed to be. So we put them in like this little box that has, we can control the oxygen in the environment, and we can keep them clear of nasty little disease floating around the hospital, and we can control the temperature and the humidity and the lighting and everything really, really well. And the thing is, it also protects from like noise and handling and all this other things and like bumps and jarring. The problem with a neonatal isolate is they're outrageously heavy. I'm not going to make up the number, but I'm going to guess hundreds of pounds, like 3, 4, 5, 600 pounds, especially when they start carrying medical gas on them. They're very, very, very heavy. So they're specialized equipment. You know, these are like cook children, stuff like that will carry neonatal isolates. CareFlight has some, but they're rare. But just know that they exist. And we do put them in ambulances sometimes. They can fit on a stretcher. It has to be a special stretcher, but they do fit on stretchers. Decon, decontamination, you need to make sure you decontaminate your stretcher after every single encounter. Doesn't matter if it was a clean patient. Wipe everything down. Look for blood. Wipe down the straps. I'm sorry. Put new seatbelt or put new sheets on. Make sure the oxygen tank's full. Wipe everything down. Wipe down the grips. Wipe down the mattress. Everything gets wiped down and cleaned after every single patient. Doesn't matter if they had COVID, Ebola, monkeypox, or a stub toe. We wipe it down, okay? Wipe down the stretcher. Decon. It's very important. Don't be lazy. That's what lazy people do. They don't decon. It's gross. Patient positioning. Again, patient positioning. I've told y'all this. Positioning is a form of treatment. Okay. So patient in shock. You don't want to sit them straight up, right? They're already in shock. You want to lay them like semi-Fowler or Fowler's position, or semi-Fowler or supine. I'm sorry. Which is like kind of like if this is a stretcher, here's flat. Semi-Fowler is like this, like just a little bit up. Patients in their third trimester of pregnancy should be positioned on their left side. This keeps coming up, so I guess I'll cover it. Y'all want me to cover it? I'll cover it. So if this is your spine, here's the patient's head. On the patient's right side is this thing called the inferior vena cava, and it's a vein. So veins collapse really easily. They're like water hoses that are really easy to pinch and collapse. Well, the idea is, this is the patient's right, okay? The idea is, as you have a baby growing in your belly, it starts pushing on that. So as it starts pushing on it, it can cause hypotension, low blood pressure, because you're obstructing the amount of blood going back up to the heart from the abdomen and the lower extremities. So the idea is, it's pretty simple. You just roll the patient on their left side, because if the patient's on their left side, then baby's no longer here, baby's over here. And guess what's not getting pushed on anymore? The vena cava. So you end up without this compression of the vena cava. And that's why it's the left side. It's tested, and that's why I'm telling you that. But yeah, the more you know, a little extra piece, a little nugget right now. Place the unresponsive patient with no suspected spinal, hip, or pelvic injuries in the recovery position. Remember, recovery positions on their side, where they basically, the reason we do this is if a patient's on their side and vomits, it goes out of their mouth. If you have a vomiting patient vomit with like on their back, it would be terrible. Like they would aspirate, they would choke on their vomit. Bad outcome. Okay. Anytime I have a patient nauseated, either I give them medicine as a paramedic. EMTs can't do that right now, but just pull out the suction, like at the dentist's office suction, and just turn it on and put it up underneath the patient's pillow. In case they vomit and go unresponsive or something like that, you can suction their mouth out. Give them an emesis bag, you know? Maintain the dignity of an obese patient. How about all patients? Let's maintain the dignity of all patients, okay? Like sometimes we do EKGs and stuff, and we just expose their breast and stuff like that, male and female. Expose their chest, and we don't cover them back up. No one wants that. So do what you would want. What would you want for your mom, your dad? You would want their chest exposed like that. Cover them up. Have some dignity. And again, I say this, and I'm not trying to sound salty or jaded. I know people don't do it on purpose. They do it because they're busy, they're distracted. They don't they don't think of it that way. I don't think people are like, I'm going to leave your chest out to embarrass you. They do it because they don't think about it. But again, do what you would want for you to your patients. I have a favorite quote. I'll just throw it at you. Patients don't care how much you know until they know how much you care. And I'll say that again. Patients do not care how much you know until they know how much you care. So care for your patients and treat them the way you want to be treated and you want your family to be treated. Medical restraints, we don't use these very often. And we'll show you how to do this in class. We'll go over this because it's important to know how to do it properly. But we've done this a few times on combative patients where you just can't get them to calm down. And as a paramedic, we can sedate them sometimes with medicine, but as an EMT, you can't. So let me start by saying it's very risky, I've told you this, to restrain someone as a paramedic, okay? You're taking away their civil rights, right? You're taking away a lot of their rights all at once. One. Two, there's a risk for litigation. There's a risk for getting sued. And three, there's a risk for harm to you and or the patient. So the patient could harm themselves in the restraints by pulling against them. So there's all these risks. So the patient must be in the supine position when preparing to secure the patient to the stretcher. So basically, what I don't want you to do is to restrain a patient with their hands above their head. Why is that? Because the patient can sit forward pretty far. So you don't want to do that. The ideal way to restrain a patient is one hand at their side, one hand above their head, because they can't move as much. You'll see, it'll make more sense in the lab, but trust me on that. It's a good way to restrain patients. If we have to restrain patients, it's used as a last resort. Remember, our safety's first. If the patient's belligerent, call law enforcement. They'll help you restrain them. Okay? Our safety's first, and then the patient. Personal considerations. These are things you really got to ask yourself to be fit to duty. Excuse me. You got to ask yourself, first off, am I prepared to do this job mentally, physically? One. Two, before lifting a patient and moving a patient, am I physically strong enough to lift or move this patient? And that's like a mental checklist. Like, this isn't rhetorical. Like, you should really ask yourself, like, my back's been hurting. Do I think I can really lift this 350-pound patient? It's a real question. Is there adequate room to get the proper stance to lift the patient? Do we need to move this patient by kind of dragging their ankles out a little bit further from the toilet to get to another provider on their right side so we can like move them? You know, so is this an optimal lift, right? How can we optimize this lift? Do I need additional help? That's a fair question, and there ain't no shame in my game calling for help to lift someone. Okay? I'm young. I'm fairly physically active too, but I got a whole life ahead of me, and God gave me one back. So it's okay to say, you know, ma'am, I'm gonna help you, and I'm gonna help you, but we're gonna call for help so we can make sure that you're safe and that we can help you properly and get you up off the floor safely. Okay? And just be honest with the patient and make sure that they know that we want them to be safe. And lastly, an injured provider can't help anyone. So again, you're thinking, wow, why is there so much talk about lifting? It's because people get hurt doing this. Providers do. So this is tested. If you have any questions, let me know. I appreciate y'all paying attention. Yeah, have a good